Without further ado, I'd like to introduce Dr. Firdos Ziauddin, Guthrie Breast Surgeon and Breast Program Leader, and Dr. Geneva Ballard, Certified Breast Radiologist and Section Chief Breast Imaging, to share more about risk factors, screening options, and more, with Dr. Ziauddin leading us off today. I'll stop sharing my screen now to allow Dr. Ziauddin to begin this afternoon's presentation. Welcome, Dr. Ziauddin.
Thank you very much. Welcome, everybody. Thank you for joining us this afternoon. We are going to talk this afternoon about breast cancer risk factors and screening. So, a risk factor is anything that is associated with an increased chance for something. So when we say breast cancer risk factors, it's anything that can increase someone's chance for getting breast cancer. There are many things you can't control that are associated with breast cancer risk. And unfortunately, these are the more impactful risk factors. For example, sex, whether you're born a man or a woman, you can't change that. And everyone knows that breast cancer is much more common in women than in men. These numbers have been pretty stable over many years, that in a year in the United States, over 250,000 women, so in 2021, 281,550 women are projected to be diagnosed with breast cancer this year. Compare that to 2,650 men. So there's about a 100-fold difference in the incidence and risk of breast cancer between women and men. But obviously, men do get breast cancer, even if it's at a much lower incidence, so men should not ignore lumps or skin changes in their breasts. These need to be brought to the attention of their doctors. Something else we can't control is getting older. Breast cancer is something that increases in incidence as women get older, and so this is a table from the American Cancer Society cancer statistics, and you can see that the peak incidence of breast cancer diagnosis is in the 50s and 60s. And while breast cancer does happen in younger women, it's much less common. Again, to point out, although it's much less common in women under 40, with only 4% of breast cancer patients being under 40, it does happen. So again, young women who find lumps in their breasts or have nipple discharge or any symptoms in their breasts should not ignore these symptoms and think, well, we can't get breast cancer. But it is true that the incidence increases with age. About 1 in 8 women get breast cancer in the United States, so it's unfortunately very common. And being a woman and getting older are probably the two of the most impactful risk factors, and again, things you really can't change. So many people think that breast cancer is hereditary, or if there's no family history, that they aren't going to get breast cancer. And many people have probably heard of BRCA1 and BRCA2, or BRCA1 and BRCA2 gene mutations. These mutations are not common. Of all the women diagnosed with breast cancer in the U.S. every year, probably only about 5 to 10% of women have one of these mutations. And it's not just BRCA1 and BRCA2. This is a list of other genes, including ATM, PALB2, it's like alphabet soup, but there are other genes. Now, we all have these genes, and when they're normal, they usually have a function. They produce proteins that do something to protect us from cancer. But when they're mutated, and there's an abnormality in the DNA sequence, they don't work properly, and that predisposes to cancer. So depending what the gene mutation is, there can be different types of cancer risks. All of these genes that are listed, if there's a mutation, there can be an associated increased breast cancer risk. But again, these are not common. On the other hand, if someone does have one of these mutations, again, it's a risk factor that cannot be changed, and it can be associated with a very high breast cancer risk. So, on average, about 1 in 8 women get diagnosed with breast cancer in the United States for a lifetime risk of about 12%. If someone has a BRCA1 or BRCA2 gene mutation, they may have about a 60 to 80% lifetime risk of breast cancer up to age 80. So they are, again, a very impactful risk factor, but one that's not very common. So this is 8 to 10 years ago, but Angelina Jolie did make public her diagnosis of a BRCA1 gene mutation and kind of publicized the option for risk reduction surgery, so having bilateral mastectomies. And other than breast cancer risk, BRCA1 gene mutations also have high risk of ovarian cancer. So having ovaries removed, so if someone does have a gene mutation with a very high breast cancer risk, it doesn't mean they have to have surgery to reduce their risk. And these are individual choices. These are shared decision making after learning about the benefits and risks of each of the options. There is an option for screening. And Dr. Ballard is an expert on screening, and she's going to talk a lot about breast cancer screening, but there are risks. There are screening recommendations for people who have high risk for breast cancer, which may be associated with gene mutations. And there is the option for risk reduction surgery, which may be having mastectomies or having ovaries removed. So other than some of these other unchangeable or non-modifiable risk factors for breast cancer, so even if there's no gene mutation, if there is a family history of breast cancer or ovarian cancer, that is associated with an increased breast cancer risk. So we don't know everything. There may be multiple genetic changes which together, maybe hereditary in a family, and which may together contribute to some increased breast cancer risk. Maybe not as high as some of the mutations which we mentioned, but if there is a family history of breast cancer, that is associated with increased breast cancer risk. Lymphoma, this has changed, but in the past, especially patients who had, for example, Hodgkin's lymphoma, may have had a large dose of radiation to their lymph nodes in their chest as part of the treatment, and as a result, there would be a large dose of radiation delivered to the breast. And so if someone was, especially under age 30, got these large doses of radiation, there has been found to be a significantly increased risk of breast cancer in these patients. Other things you can't change when you start having periods or when you stop having periods, unless you have your ovaries out. But in general, that's something that starting periods, for example, before age 12 might be associated with increased breast cancer risk, or having menopause after age 55. And again, not all of these risk factors carry the same weight. Having a gene mutation, or having a family history, or getting a large dose of radiation to the chest are associated with much greater increases in breast cancer risk compared to when you start having periods or stop having periods. Reproductive history, so not having a baby before age 30 might be associated with some increased risk, but again, it's not as impactful as some of the other breast cancer risk factors. Breast density is how much glandular tissue you have in your breast compared to fat, and Dr. Ballard is going to talk more about breast density and breast cancer risk. Some women who have breast biopsies who have diagnosis of atypical cells in their breast, atypical ductal hyperplasia, atypical lobular hyperplasia, or lobular carcinoma in situ. These are high-risk lesions which indicate an increased risk for breast cancer. And so for these patients, screening recommendations may change because they have these lesions. Lobular carcinoma in situ is not cancer, but it is associated with increased breast cancer risk. So then we can turn and look at, well, what can you change? Do you have any control over breast cancer risk? Well, the answer is yes. There are some lifestyle changes which are associated with lower risk of breast cancer. These are not, unfortunately, as impactful as some of the things you can change. So being a woman and growing older, again, those are the most impactful risk factors for breast cancer, but you can do some things which can put you in a lower risk group. So after menopause, many women unfortunately have menopausal symptoms such as hot flashes or vaginal dryness. And for many years, hormone replacement therapy has been an option for control of these symptoms. There has been replacement of estrogen alone, or there have been combination treatments like Premarin, which is estrogen and progesterone replacement. So the reason that these are given in combination sometimes, estrogen is maybe more for control of the symptoms, but giving estrogen alone increases risk of uterine cancer. So progesterone was given to be protective against the risk for uterine cancer that's associated with estrogen. On the other hand, estrogen alone is not as risky, does not carry as high a risk for breast cancer as does the combination of estrogen and progesterone. However, that doesn't mean you can take estrogen forever. Some people, if they don't have a uterus, are just prescribed something like estradiol, which is estrogen alone. Taken for more than 10 years, estrogen alone can also be associated with increased risk for breast cancer. So there can be a significantly increased risk. Again, around 75% increased risk. Now, that looks like a very high number, but remember, if you start out at like a 10% risk and you increase 75%, that will put you up to like 17.5%. We're not saying that the risk for breast cancer would be 75%, but that is a huge increase. That's not quite doubling it, but that is a big increase in risk. There may be some gradual decrease after stopping hormone replacement therapy. So there may be some alternatives, and these, again, don't work for everybody, but for hot flashes, some people can identify triggers that can start the hot flashes: drinking hot coffee, taking caffeine, drinking alcohol, smoking, being in hot rooms or eating hot food or taking hot showers. So sometimes if by staying in cooler temperatures and having food at a lower temperature may help avoid hot flashes. Some natural remedies like black cohosh or evening primrose oil work for some people. Doesn't work for everybody. There's no convincing data that these are consistently effective. And a lot of these natural products are not regulated, and there's concerns about contamination. There may be contaminants in, and they're not pure. Reducing stress, which is not easy, but if there are ways to reduce stress or have counseling, that may also, especially if stress is a trigger for hot flashes, that may be something that reduces the incidence of hot flashes. There are medications which may be effective for hot flashes. Effexor is an antidepressant, but it also has been found to be pretty effective for hot flashes. So it's a non-hormonal therapy that can be very effective for some women. Gabapentin it's a drug that's used for seizures and also for nerve pain, but it's also been in some cases found to be effective for hot flashes. These medications may have side effects, so again, sometimes it's trial and error to see which one will work. It's something you have to work with your doctor to find something that works for you. For vaginal dryness, so vaginal hormone replacement like estrogen or progesterone creams don't have the systemic absorption, that not as much may get into your blood as taking like oral hormone replacement pills. So that may be something that's an option, or using lubricants. And it's something you work with your gynecologist or primary care provider to get more information about these alternatives. For some people, there's nothing they can really do. There aren't hormone replacement therapy is the only thing that will work to reduce hot flashes or other menopausal symptoms. And if these are debilitating symptoms of menopause, there's really not, maybe hormone replacement therapy, maybe you have to take it. And I heard someone say, life is about living. And if your quality of life is being ruined by menopausal symptoms, and hormone replacement therapy is the only thing that will help, well, that may be something you need to consider. But it's something you need to discuss with your physicians or healthcare providers, weighing the benefits and risks of different therapies. All right, something else that is associated with lower risk of breast cancer is physical activity. So a lot of these studies that show lower risk or benefits of different lifestyles are from population studies women sign up. There are large epidemiological studies that women can sign up for, and then they're followed. They get questionnaires. How much do you drink? How much exercise do you get? And then they're followed. And these studies may involve 80,000, 100,000, many thousands of women. And it's not the cleanest data. Sometimes there's factors that you can't take into account. But when you see multiple studies that kind of show similar trends, it becomes kind of convincing. So, for example, for physical activity, in different studies, there's been found to be a 12 to 20% lower risk of breast cancer in physically active women compared to those who have a more sedentary lifestyle. Taking hormone replacement therapy might blunt some of this effect, however. So what is physical activity? How much should you get? So some of the recommendations from the American Cancer Society, levels of activity which may be associated with lower cancer risk, and not just breast cancer, but maybe other cancer risks, is 150 to 300 minutes of moderate activity. So that averages between 20 to 40 minutes a day of moderate activity, like walking, biking, don't have to be too fast, even heavy cleaning, like vacuuming, mopping, badminton. If you don't, I guess badminton can be even vigorous activity depending how you play it. Doubles, tennis, and then if vigorous activity, you can do a little less time every day, maybe 10 to 20 minutes a day, jogging a little faster, biking a little faster, basketball, soccer, tennis singles. But doing something, some physical activity a day is associated with lower breast cancer risk. Along with that, being obese is associated with higher breast cancer risk. So one way we often measure obesity these days is body mass index, which is calculated based on height and weight. If you go to cdc.gov, you can find a BMI calculator. So normal BMI is between 19 to 24, 25 to 29 is considered overweight, and obese is over 30. Now, before menopause, there may be a slightly actually lower risk of breast cancer associated with obesity. On the other hand, younger women who are obese and get breast cancer might get more triple negative cancer, which is a more aggressive type of breast cancer. This is not to encourage young women to be obese, because that can carry over into older ages, and obesity after menopause is definitely associated with a higher breast cancer risk, 20 to 60% increased risk. So, it's recommended to maintain a healthy weight to decrease the risk of breast cancer associated with obesity. You should work with your physician and dietitian to lose weight safely, about a pound a week, and get a plan from your doctor or dietitian. These are things that are good for all of us, having less sugar, having less saturated fat, and eating more vegetables, lean meats, and seafood. Multiple studies have shown an association between alcohol consumption and breast cancer risk. There's been hundreds of studies, actually, and there's a consistent trend. And these are just associations. We don't always know the causes, but possible causes. Alcohol can be metabolized to acetaldehyde, which is a carcinogen. There might be increased estrogen levels associated with drinking, and also obesity is a risk factor. So alcohol provides empty calories and weight gain depending on the contents of the particular drink. So there may be some benefits associated with alcohol, but not if it's not in excess. So anything more than a drink a day is associated with increased risk. So a drink meaning 12 ounces of beer, 5 ounces of wine, or a shot of heavy alcohol like whiskey. 30 to 50% increased risk associated with heavier alcohol drinking, and binge drinking especially is associated, which is 4 or more drinks at a time, is associated with increased risk. So, all these lifestyle changes, again, they may not be the most impactful They can't completely overcome family history or gene mutations, but they are associated with lower breast cancer risk, and they're good for your health overall, especially your cardiovascular health. You know, not being overweight is good for your joints. Not drinking so much alcohol is better for your liver, avoiding things like liver cirrhosis. There are some popularized but controversial breast cancer risk factors. There's not very good evidence, or there's poor evidence that things like antiperspirants or deodorants are associated with breast cancer. It's not really proven. Underwire bras, while they might be more uncomfortable, they might cause skin irritation in the fold under the breast. Not really good evidence that they're associated with increased breast cancer risk. Same thing with caffeine. Carrying your cell phone in your bra is a concern for some people. There's not really good evidence at this point that's associated with increased breast cancer risk. If you can carry your cell phone in your purse, maybe that's better, but I don't know if over time there will be an association found, but right now there's not. And one thing to remember, these being a woman and getting older, again, those are the most impactful risk factors. It's also by making some good lifestyle changes, it's good for your health. It is associated with lower risk, but it does not completely eliminate risk. You know, many women who have no family history of breast cancer can get diagnosed with breast cancer and do. Taking really good care of yourself may lower your risk, but it doesn't completely eliminate it. There are world-class athletes who have been diagnosed with breast cancer. So the point is, it's good to make lifestyle changes that are good for your health and also associated with lower breast cancer risk, but you can't completely eliminate the risk. And screening is very important, and Dr. Ballard is an expert on screening, and she's going to tell us a lot more. Thanks for your attention. Please save your questions for the end and for the chat box, and I'll turn it over to Dr. Ballard.
I'm Geneva Ballard, and I am a breast radiologist. I am the chief of the breast imaging section for Guthrie, and I'm going to be talking today about breast cancer screening recommendations in average risk women, and in women who are considered high risk for developing breast cancer in their lifetimes. So just a quick kind of pathway through the next few minutes. We're going to talk about the goal of screening for breast cancer, screening recommendations in both average risk women and high risk women. I'm going to go through some examples of 3D breast tomosynthesis. I like pictures. I do imaging as a career, so I'll be showing some of the pictures of what I do and kind of give examples of why we use 3D breast tomosynthesis to screen for breast cancer, and then also discuss screening with breast MRI, which we're using pretty extensively now for women who have high risk for breast cancer, as well as women who have very dense breast tissue. So some of these statistics Dr. Z had already touched on, but the facts are that 1 in 8 women will develop breast cancer in their lifetime. 1 in 6 breast cancers occur in women in their 40s. So while your risk for breast cancer does continue to increase, peaking in the 50s and 60s. It certainly does happen in women in their 40s, and a fairly sizable percentage of breast cancers are diagnosed in women who are 40 to 50 years old. 75% of women who are diagnosed with breast cancer have no special identifiable risk factors. This is something that Dr. Z had talked about. Really just being a woman is the greatest risk factor. Continuing to age is a risk factor, but often there's no other risk factors that we are able to identify in women who develop breast cancer. So if we were to just screen the women who we know have risk factors, the vast majority of breast cancers would be missed. So why do we screen for breast cancer? So the short answer is we screen for breast cancer to prevent women from dying of breast cancer. When breast cancer is found when it's small, and we can find it at screening rather than waiting to when a woman can feel a lump, you're much less likely to die from breast cancer. The decline in breast cancer deaths since the 1980s has been attributed both to better treatment with chemotherapy and surgical therapies, but also to early detection by mammography. Breast cancer survival is related to multiple factors, but prognosis is largely based on the stage at which the breast cancer diagnosis is made. So when we were able to find breast cancer in its very earliest stages, so stage 0 or stage 1, small tumors that haven't spread, the survival rate for those breast cancers is extremely good. And 5-year survival for both stage 0 and stage 1 is around 100%. And as those tumors grow larger and as more lymph nodes are involved or more distant spread has occurred, the odds of survival are drastically decreased. So when you're looking at the stage 0 and stage 1 cancers, those are screen detected cancers. Those are not cancers that women can feel or find in any other way. They're usually not able to feel a lump or have any symptoms at all. So our goal is to really find those breast cancers at those very early stages, and the only way to do that is with screening. By the time you're able to feel a lump, the average size for a palpable breast lump is between 2 and 2.5 centimeters. So the disease has been allowed to reach a stage where the tumor is relatively large, and in many cases may have already spread to lymph nodes or potentially spread throughout the body. So the goal of screening is to detect those very early stages when it's most effectively and easily cured. I often have patients who will be called back from screening for something that we find in their imaging, and they say, I can't possibly have breast cancer, I don't feel a lump. But that is in fact the goal of screening, is to find it with imaging before you can feel it. So mammography is the main modality for screening in early detection of breast cancer. There is some controversy and a little bit of confusion about screening recommendations, when to start, when to stop, how frequently to screen. There are various screening recommendation strategies that are given by various parts of the medical community, and so that can really contribute to confusion on the part of patients. I'll talk specifically about what Guthrie recommends, which is the same as the recommendation of the American College of Radiology, the Society of Breast Imaging, the American Society of Breast Surgeons, and the NCCN. And all of those entities recommend starting at age 40 and continuing annually as long as a woman remains in good health. So why not wait until 50? Some of the screening strategies recommend waiting until 50, but if we are to do that, tumors in younger women tend to be more aggressive, and I see women every day who I diagnose with breast cancer in their 40s, and I really highly recommend starting screening at 40 so we're able to catch those tumors in those young women. There are published analyses that show if we were to wait to start screening at 50 and to screen less frequently, so every other year potentially, we would miss 1/3 of cancers, and that could lead to an additional 6,500 to 10,000 additional breast cancer deaths per year. So all of the screening recommendation strategies have one thing in common, and that is to risk stratify patients prior to choosing a screening strategy. And that all is dependent on extensive patient counseling and a conversation between physicians and their patients, starting around the age of 30, to discuss family history and risk-benefit analysis. Often that's something that not a lot of women are given the opportunity to just start discussing at such a young age. But it's really important to bring it up with your physician, especially if you have a family history of breast cancer or other risk factors that you know of, because screening could start for high-risk women around the ages of 25 to 30, depending on your family history and risk factors. So for patients who are considered high risk, patients who have an estimated greater than 20% lifetime risk of developing breast cancer, based on an algorithm that we use to estimate the various factors that contribute to lifetime risk, those patients should start screening earlier, as young as 25 to 30. Most patients without a BRCA gene mutation would start around 30, but our BRCA patients are going to start at 25. And those patients should be offered MRI as an adjunct to screening mammography, particularly if they have dense breasts, which many of our younger patients do have very dense breast tissue. So who is considered high risk? It's anyone who has a strong family history of breast cancer, and that's going to include all of the genetic mutations that Dr. Z talked about, not just BRCA, but those other alphabet soup list as well. And that is going to be a small minority of the patients who are at high risk. We use a somewhat complicated mathematical algorithm to take into account all of the different factors that are involved in estimating a patient's lifetime risk. And we do that for patients at the time of their mammogram. And Dr. Z does it in his clinic when he's estimating patients' lifetime risk for breast cancer, so we can have that conversation about what the proper screening recommendations should be. But if you have multiple affected family members, particularly family members who were diagnosed at young ages with premenopausal breast cancer, that's a strong risk factor for developing breast cancer. Patients who've had a previous biopsy that demonstrated atypical cells, patients, as Dr. Z mentioned, who've had radiation to the chest at a young age, and dense breast tissue in and of itself is a relative risk factor. So red flags in a family history that suggest that you should potentially consider genetic testing for possibly having a BRCA gene mutation are breast cancer in the family that is diagnosed younger than 50, breast cancers in multiple family members on the same side of the family, any family who has a male member who has been diagnosed with breast cancer, and families who have had a triple negative breast cancer diagnosis. That's a specific subtype of breast cancer that's very aggressive and associated with BRCA gene mutations. And also in those families, if there are affected members with ovarian cancer, that significantly increases the likelihood that you may be dealing with a BRCA gene mutation. But there are, as Dr. Z mentioned, patients who are genetically negative, who have been tested for BRCA and all those other gene mutations, but have no abnormalities detected, but they're still at high risk. So the assumption is that these women have potentially genes that we can't test for, or that a collection of various genetic abnormalities contributes to their increased risk for breast cancer. And so they are still considered high risk and still recommended for breast MRI and for mammography in addition to MRI if they're in this particularly high category, so greater than 20% lifetime risk of breast cancer. So I tend to think of the population of people somewhat like this. So those in red have a genetic mutation that we can test for, identify, put down on paper and say, you have a BRCA1 gene mutation, you have a PALB gene mutation, and those are our extremely high risk population, but they're relatively rare in the general population. Those denoted with the black color are the other group that are actually much more frequent, and they're high-risk patients who are genetically negative. So no abnormal genetics that we are able to test for, but clearly at increased risk for breast cancer, and they should be undergoing screening with MRI potentially to help identify their breast cancers earlier. And then the general population is about the average risk, so still at reasonably high risk, 1 in 8, but not nearly as high risk as either the familial or the hereditary genetic mutation folks. So imaging of higher risk women, we tend to use both MRI and mammography, ideally with 3D mammography. We are often starting younger in these high risk women, and they tend to have more dense breast tissue. And we know that mammography is less sensitive in patients who have dense breast tissue. Often we're worried about these younger women who are at increased risk for breast cancer developing more aggressive tumors at younger ages. And we want to be able to find those early, not have to wait until they show up on a mammogram that can be potentially limited by breast density. So the years of life that are lost to breast cancer are highest for women in their 40s. Over 40% of all the years of life saved by mammography are among women in their 40s. So potentially those women are going to fall into a higher risk category, tend to develop breast cancers earlier with denser breast tissue, potentially limiting mammography for screening. So that kind of brings us to the question of dense breast tissue. There's a lot of conversation that goes on with regard to breast density and what does it mean and why does it matter. And I'll give you kind of just a breast imaging tutorial here. These are 4 different women with 4 different breast densities. So the left side of your screen is a nice, very low density mammogram, which we refer to as a fatty mammogram. So all of the kind of dark gray stuff is predominantly fatty tissue, and then the little bit of glandular tissue is kind of scattered throughout. But we are mostly able to see through that breast very well. And a cancer is going to show up as a white spot in the midst of the breast. And so the more dark gray stuff we have, the easier we're able to find a white spot. And as you progress towards the right side of the screen, more white stuff is more dense glandular tissue. So there's essentially 4 categories. Fatty breast tissue, which is my favorite. I love to read these because I can find cancer very easily. Once we start developing having more scattered breast density, it becomes a little bit more challenging. This is a heterogeneously dense breast, so more of the glandular tissue relative to the fat, but still some fatty tissue. And then this is an extremely dense breast on the far right side of the screen. Very dense, lots of white stuff obscuring potentially a small cancer amidst that. It's going to be really hard to pick up a tiny cancer in that very dense breast. And that's really the limiting factor for mammography is breast density. So this is an example of a nice fatty breast with a little tiny cancer that just popped up. And we're able to see that from a mile away and diagnose that early, and that's going to have a really great outcome. And as you can see, the dense breast we're going to have a lot harder time finding that tiny cancer because it's going to be covered up by all of this other white stuff that shows up as white on the mammogram. So that's a little bit more like looking for a needle in a haystack when you're dealing with a lot of dense breast tissue that could potentially cover up a small cancer. So fortunately, we have in the last decade developed 3D tomosynthesis, which is able to kind of help with the trouble of having so much white stuff covering up potential cancers. So 3D tomosynthesis obtains multiple different X-rays, essentially, of the breast from different angles. And then we're able to leaf through those different pictures to almost like pages of a book to see each level of the breast tissue as we turn the page. And so we're able to uncover small tumors that could have been otherwise obscured by the tissue that's on either side of them inside the breast. So here's multiple sections of a 3D mammogram. So when I'm looking at these, I look at them kind of in a stack and I sort of scroll through them. They look like a 3-dimensional picture that you're able to like move in and out of, but it's hard to show that in a PowerPoint. So I just separated these out. This is just the 2D image. So this is what we were dealing with up until about 8 to 10 years ago. And this little cancer is completely obscured by overlapping white stuff. But as you move down through the breast and you're able to separate out each level of the tissue, you're able to see this little cancer that would otherwise have been hiding in the dense glandular tissue. And that's how 3D mammography works, is to let us find small tumors that would have otherwise been obscured. So here's another case. This is the patient with a 2D mammogram. And this is actually a pretty modern 2D mammogram, very nice resolution, but still nearly impossible to find this little breast cancer hiding in the breast in this dense tissue until you're able to separate that particular slide out on the 3D view. It's still pretty subtle, but you can see it in here kind of just jaggedy and pulling in the tissue that's next to it. And that's sitting right there, which is pretty tough to see without the advantages of 3D. And there it is on ultrasound. And here it is on MRI. So a great example of how easy it is to see things on MRI, even when you're comparing something to a 3D mammogram. And this is really why we do MRI for our very high-risk patients, because we're able to pick these tumors up much more easily and ideally at much smaller sizes. So here's another 2D mammogram, and then here's the 3D counterpart. So that tumor is in here, nearly impossible to see, but nice, obvious little spiculated mass that we can see with 3D after you leaf through to the level where that tumor is sitting. And there it is. Hard to see on the 2D. Another example. That little guy is pretty hard to see on the 2D, but very obvious on the 3D. So here's another. I like pictures, and I'm sure it's kind of nice to see what we're actually talking about with 3D. This is a pretty complicated breast, lots of dense, very dense tissue, kind of a lot going on here. But on 3D, there's obviously a mass that's sitting back here, pulling in on the backside of the fatty tissue. And that's another tumor. There's another one, much more easy to see on 3D. So this is why I strongly recommend 3D mammography as opposed to 2D mammography, particularly for people who have dense breasts. It's just so much easier to uncover those tumors that would have otherwise been obscured by overlapping tissue. So that brings us to breast MRI, and we use breast MRI because it is more sensitive than mammography, even more sensitive than 3D mammography, and it improves our odds of finding breast cancer at its earliest stages, particularly in high-risk women, and especially those with dense breast tissue. So I'll show a few cases of screening MRI in high-risk patients. So this is a patient with a negative mammogram, very dense tissue, hard to see much going on there. Then had a screening MRI, and then you can see there's a tumor that was completely obscured by the dense glandular tissue, even with 3D. Another example, very dense tissue, tumor that's fairly obvious on MRI, never would have picked that up on mammography. Potentially could have seen it with 3D. I don't think this patient had 3D. This was a 2D only mammogram, but impossible to see on a 2D mammogram, and definitely a tumor on MRI. So in summary, we really recommend starting annual mammography at age 40 and continuing as long as you remain in good health, preferably screening with 3D rather than 2D mammography, especially if you have dense breast tissue. If you have a family history of breast cancer or any other risk factors, please start talking to your physician early about risk assessment, or you can make an appointment in the high-risk clinic with Dr. Z for a full risk assessment. We also do a risk assessment at the time of mammography, so we ask all the questions regarding family history and other personal risk factors and calculate a lifetime risk for you. So at the time of your screening mammogram, we're able to give you an estimate of your lifetime risk, and then offer counseling with regard to getting you in to see Dr. Z or potentially ordering MRI for you directly in addition to annual mammography. I appreciate everyone coming today, and it was kind of nice, I guess, that it was so rainy and dreary. We got a chance to just sit inside and chat a bit about breast health.
Well, thank you both Dr. Ziodine and Dr. Ballard for those great presentations. Very great and important information.